Good evening and welcome to the National Pancreas Foundation's 2021 Virtual Education Series. I'm Trish O'Neill, the National Director of Chapter Development. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the animated Pancreas Patient, our state chapters that support fundraising, patient support groups, and education, and our physicians programs that includes research grants, medical education, and our annual Fellow Symposium program. Our success depends on the support of many individuals and organizations, and you can make a difference by joining NPF as a volunteer, a sponsor, coordinating a fundraiser in your community, or sharing your own personal story. For more information, please email us at info@pancreasfoundation.org. Our topic this evening is improving daily life with adult pancreatitis, medical behavioral challenges and treatment. And our moderator this evening will be Dr. Randy Brand. Dr. Brand will be joined by a team of medical experts and will include patient perspectives. During the program, please feel free to submit your questions in the Q&A section, and the appropriate person will field those questions during the evening. Dr. Brand is an academic director of gastroenterology at UPMC Shadyside and the director of gastrointestinal malignancy early detection, diagnosis, and prevention program. He is a physician scientist with an extensive background in pancreatic diseases, mainly focused in the early diagnosis of pancreatic cancer and cystic lesions of the pancreas. Dr. Brand serves as a medical director for the National Pancreas Foundation's Western Pennsylvania chapter. He serves on the NPF Review Committee for Centers of Excellence and has done a series of early detection segments with the National Pancreas Foundation. He was recently honored at the 2019 Courage Gala in Pittsburgh and currently serves on the National Pancreas Foundation Board of Directors. Thank you all for joining us tonight, and we welcome Dr. Brand and our panelists, and thanks again for joining.
Well, welcome to the NPF symposium today. I'm quite honored to represent Western Pennsylvania's chapter of the NPF, and we're really excited about our speakers today and our panelists. I think you're going to really learn a lot. Our first speaker, so we'll get to it because we have a lot to go. We want to be mindful of everyone's time, is going to be Dhiraj Yadav. He is currently a professor of medicine at the University of Pittsburgh. He is associate clinical director of research and academic development of our gastroenterology division at UPMC. He is one of the leading pancreatitis epidemiologists, actually in all pancreatic disease. He's nationally funded in pancreatitis studies, including 2 UO1s dedicated to pancreatitis research. And he is really, along with David Wickham, one of the co-leaders of the North American Pancreatitis Study Consortium. We're quite fortunate that Dr. Yadav has agreed to speak today, and he's going to give you really an overview on pancreatitis.
Thank you, Dr. Brand. And can you see my slides?
Yes.
All right. So good evening, everyone, and welcome to the session today. The topic I'm going to cover is rather broad: pancreatitis in adults, a medical overview of the diagnosis and management. What I'll try to do is to focus my presentation to certain specific topics. For example, discussing about acute pancreatitis, abdominal pain, which is the most common symptom in patients with pancreatitis, how acute recurrent acute and chronic pancreatitis are linked with each other, the challenges that patients face, and the ways in which we work in a collaborative team to address those challenges. In contrast to, say, diseases for the heart or the liver or lung or kidneys, that patients are well aware of these organs, the first thing that comes to many patients' mind when they are diagnosed with pancreatitis is, what is the pancreas and what does it do? So if you see this picture here, this is a representation of the GI tract starting from the mouth to the anus. In the middle is the section of the abdomen. And there, if you see this yellow strip of tissue, this is the pancreas. This is tucked all the way in the back of the abdomen, in the upper abdomen, right in front of the spine. And it has intimate relationship to many important organs like liver, bile ducts, stomach, colon, spleen, and also major blood vessels that run right around the pancreas. And these are important considerations to make when we think about doing treatments for patients, especially invasive treatments like endoscopic therapy or surgery. This is a bigger or a large picture of the pancreas, where yellow is the pancreas and the pink is the stomach and the beginning of the intestine. The green is the gallbladder here, and the green line that comes down is the bile duct. The tube-like structure in the middle of the pancreas is the pancreas duct, which is like a tree trunk that sends branches into the substance of the pancreas. And an important function of the pancreas is like a factory that makes digestive enzymes. These are poured into the ducts, and the ducts make fluid, which helps to flush the enzymes through the pancreas duct into the intestine to help to digest food. And in fact, pancreas is one of the most metabolically active organ in the body. And if it is significantly affected, that could lead to malabsorption. The other important function of the pancreas is to make hormones. And the most important one is insulin, which helps in controlling blood sugars. So if pancreas is damaged, then that can lead to development of diabetes. The next is, what is pancreatitis? So pancreatitis is inflammation of the pancreas, and this can be of different types. The most common type of pancreatitis is acute pancreatitis, which presents as sudden onset of upper abdominal pain, can be one of the worst pains that somebody has had. It can often radiate to the back, and patients may also have a sense of nausea and may in fact have vomiting. There is elevation of pancreas enzymes in the blood test, and typically we look for a level of 3 or more than 3 times the upper limit of normal, as that would be more specific for the pancreas. And then there can be inflammation of the pancreas or other findings around the pancreas relating to complications that can be seen on imaging studies like CT scan or MRI. Most patients who have acute pancreatitis, about 80% patients, would recover within 3 to 7 days of onset of symptoms with resting the pancreas by keeping a patient NPO and then slowly starting the feeding. In a small number of patients, about 20%, the disease can be more severe, and that can lead to different type of complications. If somebody has more than one attack of acute pancreatitis, that is called recurrent acute pancreatitis. Chronic pancreatitis is a situation where there is chronic inflammation that can lead to scarring of the pancreas, and that, if it is significant, could lead to dysfunction of the organ, diabetes, and malabsorption, as I just mentioned. So this is a CT scan, and the way to look at it is as if you're standing at the foot end of the patient and looking up in a cross section. This white structure here is the spine and 2 kidneys on the side, and right in front is here the pancreas, which after a contrast agent is given, lights up, and it looks very similar to how a liver or spleen would look. This is a CT scan of a patient who has acute pancreatitis, where you do not see the black things around the pancreas, which is the normal fat, but you are seeing this area as very white, which is relating to inflammation that is set up around the pancreas relating to to inflammation. The next question which comes up is what causes pancreatitis? So here are some of the common causes. This is not an exhaustive list of acute, recurrent, acute, and chronic pancreatitis. One thing you will observe here is that there are many causes that cut across the different types of pancreatitis. Another important thing is that there are many of these causes that can actually be addressed. And this is important when we are thinking of managing patients, because if you are able to identify the cause of pancreatitis and eliminate that, for example, if there are gallstones and you remove the gallbladder, or if there is a medication or there are high triglycerides and you address them, you can actually significantly reduce or in fact eliminate future attacks of pancreatitis altogether. With regard to chronic pancreatitis, until the last few years, it used to be believed that heavy alcohol consumption is the predominant, or sometimes people will say the only cause of pancreatitis is not completely true. We are learning that chronic pancreatitis is a complex disorder where there are other factors that are also important, if not equally important. For example, genetic factors and others that I'm happy to answer any questions during the Q&A section. This is a slide that shows the relationship between the different types of pancreatitis. Acute pancreatitis is the most common form of pancreatitis. And about 1 in 5 patients who have an attack of acute pancreatitis, they will have another attack of pancreatitis during follow-up. A subset of patients with recurrent pancreatitis can transition to chronic pancreatitis, and many patients with chronic pancreatitis can actually present without a prior attack also. Chronic pancreatitis is also a risk factor for pancreas cancer, although it is important to remember that this occurs in a small fraction of patients. The important thing to remember in this relationship is that if we are able to identify ways in which we can prevent recurrence of disease and also slow the progression, that could actually help in improving not only the symptoms of the patients, but also destruction of the pancreas and prevention of diabetes and other complications. What are the most common symptoms and signs of chronic pancreatitis? Abdominal pain by far is the most common and most troublesome symptoms of patients. It is present in about 9 of 10 patients with chronic pancreatitis. Patients can have 1 or more attacks of acute pancreatitis. They can have diabetes or malabsorption. One thing that the patients may not realize is that poor bone health is a very important complication in patients with chronic pancreatitis, which could lead to osteoporosis, osteopenia that is typically associated with older age. It can also lead to increased risk of fractures. This is something that can be preventable if an early diagnosis is made and treatment initiated. And then there are other symptoms often related to complications of chronic pancreatitis. Going into a little bit more detail about abdominal pain, the type of abdominal pain, severity of pain, and how the pain occurs over time can be highly variable between patients. And this is an example from a very large study that was done recently in the Netherlands. In the bottom, you see a patient who has attacks of abdominal pain. This could last for a few hours to a few days at a time, but in between attacks, the patient has no symptoms at all. Then you can have patients who have constant pain, and within constant pain, there can be high degree of variability in terms of how often there is fluctuation in pain, how often there are attacks or flare-ups, which may even need admission to the hospital or visit to the emergency room. How often do patients have these type of symptoms? So this is a very large study from the NAPS2 database. This is a study Dr. Brand mentioned is conducted over 30 centers in the United States over the last 20 years. In over 500 patients, when it was asked in the past year, describe your pain experience, about 55% of patients said that they had constant pain. And about 2/3 of patients said, which is shown here in this red bar, is that they had severe pain at least at some time during the past year. And about half of the patients had significant pain that they needed pain medications, including narcotics. This is another study from the Dutch group, which shows that over time, the pain experience can be highly variable, or it can vary within an individual patient. So over a 4-year period that you see here in different colors, when patients were asked each year, how was your pain? And as you can see, patients can change the pain pattern from no pain to intermittent or constant or severe, even in the setting of receiving treatments medically or surgically. This actually brings up the complexity of pain in patients with chronic pancreatitis. So what causes pain in patients with chronic pancreatitis? There are a host of different reasons why patients can have pain. When we evaluate patients, we look for reasons not only in the pancreas, but also outside the pancreas. For example, is the gallbladder causing problem? If there is there an ulcer in the stomach that could be a problem? Once we think that the pain is coming mainly from the pancreas, then there are two specific things that we look for, whether there is something called a plumbing problem. What that means is the pancreas tube obstructed by stones or strictures that can be treated by putting in a stent or crushing the stones. Or there is a wiring problem. That means are the nerves that are supplying the pancreas affected, or the way that they are relaying the information to the brain affected? And Dr. Szigethy is going to talk to you a little bit more in detail about how to address symptoms of pain and the ways to manage pain. Chronic pancreatitis is also shown to have profound effect on quality of life of patients. And this is again data I'm showing you from the NAPS2 study. In the left panel is data on physical quality of life, and the right is data on mental quality of life. 50 is what an average is, and that's the dark black and the somewhat lighter black bars are for control populations, and the lighter bar is chronic pancreatitis patients. How do you diagnose chronic pancreatitis? We depend on a good clinical history, evaluating the symptoms of patients and also the burden of symptoms patients have over time. Risk factors of pancreatitis, family history could be very important because pancreatitis can run in families, prior attacks of acute pancreatitis. Lab tests are helpful, especially when somebody has acute flare-ups of disease, but we rely mostly on imaging studies. Typically, a CT scan is the first test, but if that is not helpful enough, then we do an MRI or MRCP, and in a smaller subset of patients, an endoscopic ultrasound that can take finer pictures of the pancreas through a special scope that can sit in the stomach and take pictures of the pancreas. This is an example of a CT scan of a patient who has chronic pancreatitis, where you see, rather than seeing the normal gland that I showed you earlier, you are seeing these whitish spots, which are stones in the pancreas tube, which is dilated as shown by this dark line, and you see very little substance of the pancreas. In this situation, it is fairly easy to make a diagnosis of chronic pancreatitis. This is a different patient. This is an MRI showing the pancreas duct and also dilatation of the side branches. Again, fairly easy and simple to make a diagnosis in this situation. But when you don't see these findings, sometimes we do something called MRCP in addition to MRI to get finer pictures of the pancreas duct, and also give a hormone called secretin to get some idea about pancreas function, which is shown here by the fluid that is going into the intestine that you can see. But in a patient with chronic pancreatitis, this could be affected, and also the way that the pancreas affects is lighting up can be different. Going on to the treatment for chronic pancreatitis, I'll touch very briefly upon that, but we'll be happy to answer questions. There are several important considerations that we make when we think about treatment. And the thing that I would like to highlight here is that not only our center, but most of the clinical centers, especially NPF centers of excellence and other major centers, have a multidisciplinary team of physicians and health professionals who interact with each other in making treatment decisions. We take into consideration the burden of disease somebody has, the trajectory of symptoms. We discuss the goals of treatment with patients. We look at how the pancreas looks on a CT scan or MRI to make a decision with regard to whether endoscopic treatment or breaking the stones or putting in stents is going to be helpful, or maybe thinking about surgery in specific circumstances. If we do not see evidence of pancreas duct obstruction, in that situation, maximizing medical management and ways in which we can treat pain is helpful, in addition to asking patients to limit risk factors, for example, cutting down on alcohol or smoking and other factors. And you have to be balanced between medical therapy and invasive therapy based on some of these considerations. There are many questions that patients have. For example, how can I get rid of the abdominal pain? This is by far the most common questions patients have, and rightly so. Will I get another attack of pancreatitis? And if so, when? And what can I do to prevent this? Will I develop diabetes or malabsorption? Can chronic pancreatitis be prevented? Will I get pancreas cancer? And how does pancreatitis affect my life? Will I live long enough, or it is going to affect with the duration of my life? So answer to some of these questions, or many of these questions, we discuss with patients, but we at the same time acknowledge that we as physicians and researchers do not have answers to all of those questions. And this is one reason we need participation of patients in understanding and learning from them, so that we can apply this information to other patients. And to that, I bring up this slide, which is, there are many ongoing national studies that are going where multiple centers are collaborating with each other to try to understand complex issues in patients with different types of pancreatitis, so that we can understand who are the patients who are at risk for recurrent attacks, who are the patients who are at risk for progression of disease, what are the best ways that we can address pain management, preventing complications. Examples of this is consortium studies like CPDPC, where there are two studies called PROCEED and INSPIRE in adults and pediatric patients, understanding the natural course of disease during treatment. SHARP's trial, which is a trial of endoscopic treatment in a very select group of patients who have pancreas divisum and recurrent pancreatitis. A new consortium that has been established to understand diabetes after acute pancreatitis, which did not used to be recognized previously well. A study to understand outcomes of total pancreatectomy and islet autotransplantation, who are the best candidates for this treatment and how we can improve outcomes. And then what is the best way for us to prevent pancreatitis occurring from treatments that we do, for example, ERCP, which is the SVI study. And I'll stop here, and I'll be happy to answer any questions in the Q&A section. Thank you.
Thank you, Dr. Yadav, for that excellent discussion. Just since there's some latecomers, please use the, just remind you, we're really here for you. We're honored to help support the National Pancreas Foundation. It's wonderful advocacy. Their main and very important mission is the care of patients with pancreatic diseases. And so please, if you have questions, there's no dumb questions. I can't guarantee that all of our answers we'll know them all, but we'll certainly do our best. So we encourage you to use the question and answer area box there. Just for those of you who are late, just keep in mind, we're going to have one more talk, then we're going to have a panel of two patients that are going to share their experiences with pancreatitis. And then we'll have some more open time to end the evening with questions from the attendees. So our next speaker is Dr. Eva Szigethy. She is a MD, PhD, a psychiatrist certified in adult, child, and adolescent psychiatry. We're quite lucky at Pittsburgh to have her. She's been here since 2007, serving as a professor of psychiatry and pediatrics and medicine at the University of Pittsburgh School of Medicine. She's become very integrated with our GI group, both as a co-director of our inflammatory bowel disease, total care specialty medical home, and also working with our pancreatitis patients. She is going to be speaking today on how the brain-gut connection can reduce pain and improve quality of life. So thank you for your participation today.
I'm delighted to be here and thank you for having me. And I'm going to now share my screen. In theory, I'm going to share my screen. All right, am I sharing my screen?
No, not yet.
Oh dear.
You have to hit that second share there.
I see that.
No, yep, now you got it up. So now you just got it, yeah, perfect.
All right, and I am there. Hit all of you so that I could see my talk. So I'm going to be talking about the brain-gut connection. So really thinking about what the evidence is and really hopefully offering some useful techniques in terms of what can be done to use the brain as your most powerful neuromodulator, reducing the pain and thus improving quality of life. So pain, we talk about pain a lot, and it's so important to start this talk by reminding all of us that the definition of pain is an unpleasant sensory and emotional experience, the two being intertwined. And it can be from actual or potential tissue damage. Chronic is anything lasting for at least 3 months that is constant or 6 months intermittently. So it doesn't take much to go from that acute phase that Dr. Yadav was talking about to this chronic phase. And now, sort of from a behavioral perspective, as chronic pancreatitis becomes chronic, it's difficult to diagnose and perplexing to treat. The subjective personal experience becomes more and more intertwined with how the disease sort of progresses and how much impairment there is on life from that pain. It's frustrating for patients and clinicians because it can't be measured except by behavior. So we don't have any tests for pain that we can yet reliably use. And again, even though it may and does originate from a physical source, it effect on the brain, I like to say, outshouts whatever the physical source is and becomes more and more of an impairing disease. And it can really disrupt life relentlessly. So the hopeful part of pain is it is a modifiable experience. So we have beliefs about our pain. We have expectations of whether it's going to get better or not. Our pain conditions us often to be less and less active or more and more disabled. There's a traumatizing aspect to pain that I think is only now and maybe enhanced by the year that we all spent at various degrees with COVID traumatization, but that really does impact how our brain perceives that pain experience. Obviously, we have the body chemicals from the pancreatitis itself, and all of those things have direct or indirect impacts on our brains. Then we have what's happening in our brain. So how do those brain areas that modulate our cognitions interface with our emotions and influence our behaviors? And with chronic pain, it's very common to see things like hypervigilance, catastrophizing, emotions like depression, anxiety, anger, and often a lot of avoidance, disability, and lots of sleep disruption. So vicious cycles, but again, all of these kind of domains that I'm identifying here are modifiable And I think of treating chronic pancreatitis from a brain perspective as peeling away the skin layers of an onion, sort of one layer at a time, and each peel leaving us a little bit more comfortable. So in terms of the brain's perception of pain, and this is a model that was developed by Mark Jensen, who studied how the brain reacts to chronic pain. And roughly speaking, we have a whole network in our brains that we call the behavioral inhibition system. And that's really the part of our brain, especially as the pain becomes chronic. And I apologize that my Newfoundland is joining my talk, so hopefully we'll stop soon. So our thoughts begin to signal the pain is dangerous. We begin to anticipate punishment. We understandably have reactions of great anxiety and depression, and our behavior becomes shut down, withdrawn. Fortunately, we have some in the same and some in other brain regions, an activating system. And that activating system, it allows us to think about pain as hurt does not have to mean harm, that we can begin to anticipate reward, return and turn on our emotions of joy and optimism, and begin to return to goal-directed behavior. And so when we're talking about resetting our brain-gut axis, there are a number of different kinds of techniques that I'm going to talk about today, but everything that I'm going to talk about is about turning on the brain activation system, so our positivity network. And when we do that, we are not having that negative inhibition network is activated. And so we can facilitate positive thinking and emotions. And study after study across many chronic pain syndromes shows that it is our mindset that can have a big influence on how severely and disabling we experience the pain. So I'm going to talk about 3 ways the brain can help. We're going to talk about resiliency reset. We're going to talk about brain-gut behavioral therapies, and we're going to talk about brain-gut neuromodulators, so medications that can help. Again, bring the brain online to mitigate, to reduce, to dampen, even when there is a signal coming from the gut or the pancreas in this case, then we can have a powerful tool in, again, mitigating the suffering and the disability caused by the pain. So resilience is really a fancy word for our ability to cultivate adaptive responses to turn back to a state of our optimal baseline health, so where we sit in equilibrium when we're not in pain, after we've been challenged by a stressor, in this case, pain signals from our pancreas. Often, again, even further exacerbated if now on top of that we add life stress, the social isolation that we all faced during this last year. So there can be sort of a layered attack on our resilience, and our ability to reset from that is what we call resiliency. So this year, I was actually asked for our UPMC system to design a way to help our healthcare providers reset from resilience. Then I started to use some of these concepts and techniques in our chronic, our behavioral clinic in gastroenterology, where we also see pancreatitis patients. And RESET acronym that really works. And all of these different 5 points have a vast evidence supporting that they're resetting emotional cognitive regulation and can reduce pain. Relaxation techniques, so things that we can do to reduce our arousal or our hypothalamic adrenal axis response to stress. Exercise or other activities that help us release stress for the first E. So they lead us to a sort of a joyful absorption. So they distract us from unpleasant signals coming from our body. The importance of sleep, protecting our sleep, having good sleep habits, getting as close to 8 hours of sleep, even if there are some interruptions. Quality, but quantity also matter. Emotional re-regulation, so becoming more aware of when our moods are shifting, even before they become a diagnosis of anxiety disorder or depression, and knowing and going to techniques to reset that emotion to a more positive state throughout our day. So really making emotional re-regulation in many doses part of our daily routines. And last but not least, the T is thinking positively. So optimism in the face of adversity and our ability to cultivate, sometimes reaching back for fond memories, sometimes reaching forward to really absorb ourselves in dreams that we have of what we want to accomplish and goals. So again, it can be in either direction, but there are many different tools out there that can help reset from a pessimistic negative stance, which has been shown using functional imaging brain studies to increase the firing in those brain areas that process pain, whereas optimism does the opposite and shrinks those areas of activity and corresponds to a reduced pain self-report. So brain gut therapies for chronic pain, the ones that have been most studied are cognitive behavioral therapy, medical hypnosis, and mindfulness meditation techniques. All of these are different techniques that leverage the fact that our emotions, thoughts, behaviors, and pain perceptions are connected. And they use various techniques by trained therapists, various doses, and all of them involve habit reversal. So helping the brain unlearn the way that it's been coping chronically with a stressor, in this case, the pain coming from the body. It involves reinforcing new learnings. And with hypnosis and mindfulness, the state of mind, which we call a trance, is an important part of allowing us to have a different relationship between our brains and our bodies. All these techniques have a broad literature of effectiveness and all have been associated with changes in our underlying brain circuitry. So just as a specific example, resetting the brain with cognitive behavioral therapy. So the event trigger here is pain, and we could either respond, and often the initial sort of automatic brain response, quick response before we can even think, is an alarm stage because that pain is triggering physiological, chemical, hormonal changes, but also very quickly following, we automatically as humans have a cognitive emotional appraisal of the situation. And it's actually that appraisal that will decide the level of feelings of threat, panic, fear, depression, and how activated our bodies become in response to those negative emotional states. And so an adaptive response allows us to access our internal coping skills that help us search for safety, coherence, so meaning, coping skills that help us feel better. So all of that geared toward reducing our alarm response. But often, if we don't have those kinds of techniques learned or handy, then we become preoccupied, even strengthening our anxiety, panic, leading to hopelessness, helplessness, and eventually depression and what is called the resistance stage of a stress response. Our adaptive strategies, however, help us to learn problem-solving coping strategies, leading to resilience, so that reset and constant practice of this. So really making these kinds of behavioral techniques part of your daily routines is and has been shown to maintain these effects, even in the face of ongoing pain signals from the gut. Many biological effects have been reported in very well done studies with our brain gut therapies. So changes in brain activity, body metabolism like blood flow, muscle recovery, reduction in inflammation in our bodies, and improvement in gut functioning, resetting our autonomic nervous system brain-body balance, reversing the effects of chronic stress. And there are even, when there's been either direct brain trauma or traumatization from something like chronic pain, these kinds of techniques have been shown to reduce those. And last but not least, helps put us in that safety zone to be able to fall asleep easier and more restfully. Now, I could spend a whole talk on the technology enhancements that are now available to help us go into states that are more conducive to allow our brains to counter the pain. I think some of the two, and I have no financial relationship to either of these companies, that I think have been tried and true meditation apps out there. You download them, you get a very brief free trial, and then there is a small amount that you pay. But Headspace is guided meditation and mindfulness training. That's excellent. Calm also is mindfulness meditation. All of them have various programs, different lengths, and allow you to track your progress. So the last category, neuromodulators, and there's central neuromodulators, so those things that act predominantly in the brain, and there's peripheral neuromodulators affecting the pathways that connect our pancreas to our brain. And I was very fortunate to be part of a Rome 3 work group where we actually wrote a defining document covering what is available in the literature to support the use of these kinds of agents. Again, to tone down the pain, but always working better when used synergistically and together with those behavioral kinds of techniques that I covered. So if we think about the rationale of using chemical neuromodulators for chronic pancreatic pain, and this slide is courtesy of Doug Drossman. If we think about chronic pancreatic pain as starting with peripheral nociceptive damage, some of the routes that Dr. Yadav had covered, starting with peripheral treatments may have some initial benefit, but over time, the nociceptive, so the damage at the actual nerve endings, begins to alter the pain processing system, so that connection, that highway to our brain, and we start to have central sensitization. So we start having changes in our brain and brain functioning, even some neurodegeneration. So some of our brain regions can start shrinking, and others, the ones that are processing the pain, grow in their place. So as the pain becomes more chronic, it does become critical to think about how we're targeting things at the brain. That's called a central anti-nociceptive method. And often this is done with multidisciplinary approaches. And in this case, again, involvement of behavioral providers and providers who prescribe the central neuromodulating agents. So again, more information here that I can cover, but I think we begin to classify different types of antidepressants. They're called antidepressants, but we understand that many of these medications modulate the areas of the brain not just involved with affect regulation, but also where the pain signal is received in the brain, and then also have effects actually reducing inflammation and affecting processes in our gut. And if these initial medications are not effective at titrating to the proper doses, and of course, mitigated by tolerance of side effects, there is a growing number of both chemical and then again, some of the psychological treatment methods that I covered. So again, anytime that a chemical neuromodulator is being used, really important to be thinking that there should be a behavioral therapy component, either self-guided with reset techniques or guided by a therapist. And when we think about the benefits of central neuromodulators, in addition to modulating the pain pathways, they can treat the comorbid anxiety and depression that is often hand in hand with the pain. Like I said, they can have peripheral effects in our gut. And there is some growing evidence that some of our central neuromodulators may actually help nerve cell regrowth, so neurogenesis, to counter some of that neurodegeneration. And, as I'm talking about all of these strategies, the last food for thought that I wanted to leave you with is how important whatever reset strategy, whether we're using our coping skills, behavioral strategies, whether we're deciding at what time points to take our medication, more and more we're understanding our circadian cycle. So our circadian cycle is a natural rhythmic clock that all of our physiological chemical processes are on, including a release of cortisol when we're more sleepy, when we're more awake, when our melatonin, an important hormone in our brain that tells us it's time to sleep, especially when coupled with darkness. And there's a growing appreciation that the more we can match what we're doing to help ourselves move past the pain with our unique cycles, the more effective whatever we're doing as a strategy will be. So in summary, then, I think that it's pain, chronic pancreatitis pain is a very complex phenomena, but I think if we can think about brain gut therapies, the positivity, acceptance, empathy, and gratitude of reset strategies, and all of those augmented by neuromodulators, chemicals if needed, are geared toward reducing our stress reactivity, increasing our relaxation response, and an important final point, increasing our connectivity within ourselves and to others, all of those having huge protective effects against the severity of the pain and helping us to develop more resiliency and return back to our health and return back to our lives. So thank you. And I'm also here to answer any questions.
Well, thank you for that wonderful talk. Both of our speakers were outstanding. Just to keep things moving along, because I know time is getting late here and we want to have time for our patient panel, I'm going to ask Dr. Yadav to introduce our two of his patients who have kindly agreed to have a discussion with us. So, Dr. Yadav.
Yes, thank you, Dr. Bryan. And two of our patients, Diana Bourne and Melanie Eccles, have volunteered to participate in today's session to share their experiences with you all. And we are really very grateful for them to do that. I wonder if Diana and Melanie, if you could just unmute yourself, and maybe we can start with maybe if you could introduce yourself. Maybe Diana, you want to go first?
Certainly, not a problem. My name is Diana Bourne. I've been dealing with pancreatitis, acute pancreatitis, for 17 years now. So started in my very early 20s, where all the doctors just kept saying, "You're too young to have this happen." And it was, well, thank you for the compliment. However, can we now figure out what's wrong and can we fix it? So it's been a very long road. I'm also a mother of two children who have also had to go through this road with me. So there's always that challenge, but I have a great support person of my husband who's there, which makes a big difference. And as part of my day job, when I'm not recovering or having an attack of pancreatitis, I'm an engineer. So I wouldn't call it a super stressful job, but it can have its moments.
Thank you, Diana. Melanie, do you want to introduce yourself and also describe your experiences with pancreas disease?
Yes, I just wanted to thank you, Dr. Yadav, for asking me here today. And my wish is that something I say might be helpful or comforting to someone else. I had my first bout of pancreatitis about 13 years ago. I was in and out of the hospital several times over the course of a couple of weeks. I live in Northwest Pennsylvania, and it's just kind of a small community hospital. And I was there, like I said, off and on. And eventually I was released, and I got healthy again, and I had absolutely no problems for about 4 years. And then starting about 5 years ago, I started getting sick. And quite honestly, I didn't actually associate it with pancreatitis because I didn't have pancreas pain at the time. What was happening was that every time I ate anything, I got terribly ill. And I lost my job. I couldn't work. I was homesick all the time. I tried doing food diaries and nothing seemed to make any sense. And this went on for 1.5 years. I saw 2 gastroenterologists during that time. And both of them basically at the time just kind of threw up their hands and told me that all my tests were normal. And basically I was a hypochondriac. So I was very discouraged. My husband and I were very discouraged about this. And then I did start developing really bad pain, and I ended up in the hospital again. And my local hospital sent me to an Erie hospital, and they didn't know what to do for me. And Dr. Yadav in Pittsburgh at UPMC agreed to see me, so I was transferred down there. And Dr. Yadav figured it out. I mean, ultimately what I have is pancreatic insufficiency, but he discovered that I also have 2 genetic markers. I have a delta 508 mutation, which I share with my niece who has cystic fibrosis. She and I both take the same medication. Now we're both on Creon. I didn't know that a delta 508 would affect my health. I thought I might be a carrier. Obviously I could be, but that was very surprising to me. And he also found out that I have a SPINK1 mutation. I also have pancreatic divisum. So those 3 things together, I guess, were just like this, the silver bullet. But Dr. Yadav, I think he saved my life because I had lost so much weight and I had been sick for so long that honestly, by the time I got to UPMC, I kind of felt okay with leaving the earth. I had just had about enough. But Dr. Yadav figured it out, and I'm very thankful for that. And since he figured it out, and I have been the past 5 years, I have episodes where I get really severe pain, and he has prescribed some medications for me. It happens about a couple times a year, maybe once a year. The past year has been really good, though. I haven't had to contact him for any reason. That doesn't mean that I haven't been down with my pancreas. I have been a couple of times. And I guess I've pretty much answered the first question. I hope I didn't go on too long.
Right. So let me ask a question to both of you. What has been the most difficult symptoms for you, and how has it affected you? We'll start with Diana.
And I don't even know if you really call this a symptom, but mine is I have no idea when an attack is going to happen. And then in those 17 years, to be completely honest, I've lost track of how many times I've been hospitalized for acute pancreatitis. It's at least 16. The only reason I know that much is after 10, my husband and I stopped counting, and it's been 6 in the last 2 years. So over 16, sometimes it was once a year, sometimes it was never for a year. But the last 2 years have been really bad with 6. So I can have 5 minutes, like we can be having this conversation, and in a couple hours, I could be heading to the ER. I have no warning. My acute pancreatitis is caused by the high triglycerides that we haven't been able to figure out how to control. So we do know what's at least causing it, but there's no home triglyceride meter like we have, for diabetes. So even with going and having blood draws done weekly, it's still not enough to give me any type of warning on I'm going to end up in severe pain, vomiting to the point where I could become so dehydrated. I almost died once. So for me, that symptom is just, I don't have symptoms. I can feel perfectly fine and completely healthy, no pain, and anywhere between 5 minutes and 5 hours is all the warning I get before it's drive down to the emergency room down at Presby, because I've tried the local hospitals, and I've been sent down to Presby by both ambulance and by life flight. So we just go straight down to Presbyterian Hospital now. So my worst symptom is I have no symptoms.
All right. Melanie, how about you? What's the most difficult, I guess, impact? Because really what Diana is very important, how it impacts your life and how you deal with it. The unknown.
I don't have the repeated problems that she has. Mine tends to go along pretty evenly. And I mean, like even today, I can feel it. I can feel my pancreas. It's probably at about a number 3. There's hardly a day goes by where I'm not aware that it's there. It's letting me know that it's there. But I think on a day-to-day basis, the thing that impacts me the most is nausea. I suffer really badly with nausea. I have it a lot, especially in the morning. I can't eat properly sometimes. It's hard to get, it's hard to function when you have a really high level of nausea. Now, the Dr. Yadav has prescribed me a medication that's very effective. I try to take it as little as possible, but on a day-to-day basis, that's the one that impacts me the most. When I do have higher pain, I try to work through it and ignore it. But once it gets to about 6 or 7, I'm pretty much done. And at that time, I'm just basically on the couch, and I put heat on the front and on the back, and I lay on my right side. And I often will go to a liquid diet or just try nothing at all with just some water until it starts to feel better. And that seems to work pretty well for me. It lasts anywhere from 3 to 5 days, and then I'm up again, and I'm functioning just fine.
All right. Thank you for your answers, Diana and Melanie. What I would ask is, are there 2 or 3 things that you would want to tell or share with everyone with regard to when you do have pain symptoms, or you're just not feeling well? What helps you to get through that episode of pain or experience that you are having?
I can go first if you wish.
Yeah, go ahead, please.
For me, really what helps me is I think about all the things I want to be doing when I feel better. I make lists of things. I'm a big list person. And I just always try to think of all the different things that I'm looking forward to doing, and all the different things I'm looking forward to eating when I feel better as well. I don't know. I just try to stay positive that way. I don't have the surprise attacks like Diane has. That must be very demoralizing, I would think. But I just try to remain positive and think of the future, really.
Yeah, Diana, what would you say?
I agree. I'm a list person, so I'm right there with you with that one. One of the things that more recently that I have found that actually helps is a zero gravity chair or lounge chair. You can find them at any of your local sports stores, your Walmarts, any of those places. My mother-in-law decided to buy us a swing of these. My kids loved it. And I found when I was hurting, for whatever reason, sitting in that position, I ended up getting an adjustable bed as well, trying to be able to come home from the hospital and actually sleep in my own bed instead of in a recliner or on the sofa. And that zero gravity position, for whatever reason, how I guess it just puts everything where it's supposed to be and has eased the pain for me. And then just remembering to breathe. I found out when I had kids that I hold my breath when I am in pain, and that actually does not help your body at all. So it's, just remember to keep breathing, slow breaths, and keep going. But as one of the most painful things that I have ever lived through, which includes natural childbirth. If anybody else has some suggestions, I'd love to hear them.
I put heat on mine, like damp heat, moist heat. And I don't think I'm sure it doesn't do anything to my pancreas, but I know when I'm in pain, my body clenches up. And I think just putting heat on the front and my back on the right side helps relax those muscles, which maybe makes it less intense. It seems to help me anyway. Maybe just to help my muscles relax helps me be more comfortable.
I'm gonna give it a try.
Go for it. I've never heard of the zero gravity chair. I'm gonna check it out.
I wanted to thank both of you. I'm gonna have you join the panel discussion, so feel free to chime in. But there's a few questions that I think that have come up that I think are relative to the whole group to hear and would be best served answering live. So, Dr. Szigethy, there was a question that was asked about: are there any studies to establish the connection between stress and pancreatitis, and if so, are there established stress management measures that have proven helpful?
So stress is a complicated term. And so certainly it has been recognized to be associated with chronic pancreatitis. I think that when we say cause, it's really, really hard to show causal studies. And I know that there are strong association studies, but I think in general, knowing how the brain and the gut are connected and wired just in humans, I think that stress management is really about, in a very simplified way, it's about examining your life, examining your reaction to the things in your life that you consider stressful. And it might be a whole one set of things for one person, another for another. So it's a really personalized list. And then really having two buckets. Is this something I can control or do something about? If yes, what is that going to be? And let me practice. A new skill, a new habit takes practice. And let me try the anti-gravity chair until it gives me optimal benefit. And then there are lots of things that end up on stress lists that we can't change or control. That's where we're thinking about how can we change our emotional mindset, our cognitive mindset, to literally know that by doing so, even if we can't close that door of the pain coming into our brains and flooding us, we can dim it because we can close it. And you mentioned the warmth and the heat. So there are ways through meditation, through suggestion, when you're in a state of calm, and we are all more suggestible when we're calm and relaxed, and conjuring up those images of warmth and heat. There's a very powerful technique where you close your eyes And if heat is something that is helpful, and for some people it's cold, a numbing cold helps more than a warm heat. But whatever it is that has the positive association for you of changing that signal of pain, you actually close your eyes and you imagine your hand turning either hot or cold. And with a guided therapist or a hypnotherapist, even a meditation leader, there's ways that your hand really starts feeling, will go the warmth. And then you're asked just to put that warmth right in that area and feel the soothing. And by doing something like that, by making an audio recording of that, you now have taken away the need to have an external prop like a heating pad. And so it allows you to feel more in control. So I think stress management to me is about, the appropriate discrimination of controllability. And often it's hard to come up with your own strategies, especially when you're in the middle of distress. So that's where working with a trusted other, a medical provider. I mean, sometimes it's peer support or friends and family is so powerful. Diana, for your stress of that unpredictability of the attack, I was thinking, and this is a brand new science. So one of the many roles that I play here at UPMC is I get to sort of vet any new health technology that is cool and possibly could transform how we deliver care. And there's a technology that is coming out of the Fitbit and the Apple Watch world called passive sensing. So we track temperature, our temperature all day automatically now. We track our blood glucose all day now. We can track our heart rate variability. So there's things that are very easy now to track. And more studies are showing that you probably do have some premonition signals of change in your body. Not fast enough for it to be a cognitive recognition. And so, for you, I would be really locking you on to first of all, my circadian rhythm slide that I had. I'd be really thinking about sort of what are things that we could track, maybe with gadgets or devices you already have, simple as the iPhone and a little Fitbit bracelet, and beginning to work with you. And I think so much about management of pain is about empowering. And, imagine for a moment what it would be like if you were able to come upon that signal, and then all of a sudden the unpredictability could become a little more predictable, and how much comfort and relief could that give you? So I wish that I had pat answers for everybody. But I think that I tried to use the two of you as just sort of the examples of already building off what's working, what you do well, or the aspect of your problem causing most distress, and really problem solving around that aspect.
Okay, thanks. That was a great answer. I have a few quick ones. We only have about 5 minutes left, so I'm going to ask the panelists to keep their answers very focused. This person has the same divism and CF carrier and awaiting results of additional genetic testing. And then they asked, did Creon make a big difference for you?
Creon made a huge difference. From the time I took the first pill, I started feeling better, because I think what was happening was that I just wasn't getting any benefit from the food I was eating. And I was basically kind of starving to death when you think about it. But when I have pain, I just go to a liquid diet. I drink clear broth. I drink clear juices. I drink water. I might have some clear tea, like a spearmint tea or something like that. Whatever. I don't have anything solid at all, because when I was in the hospital, it was nothing by mouth at all. But I don't want to get dehydrated. So I just basically stick to liquids. And when I start feeling a little better, I'll start maybe with a little bit of a bland diet. I don't think that's because it's a choice, actually. It's just all I think I can manage, maybe a potato, some oatmeal, something like that. But otherwise, I mean, just a diet in general, you have to be really disciplined, and it's difficult because recently I made myself not feel well because I had a piece of Kentucky Fried Chicken, which I absolutely love. But you can't be doing that really if you want to stay well on a 24-hour basis. So you have to be very disciplined in your diet. Stay away from the fried foods, eat the good stuff. There is a webinar on diet that you folks did, I think, a month ago, which is available online now. So check it out. It's got recipes as well. It's really good.
Good. Okay. So Dhiraj, Dr. Yadav, I have a question for you, sort of a summary of some of the ones that you've been kindly answering in the box there about what non-pharmacologic interventions do you counsel your patients about, to your pancreatitis patients, to help them in terms of maybe lifestyle modifications, things they can do in a preventive sort of way, as
Correct.
opposed to dealing with the actual attack?
That's actually a very good question. And much of that actually, as when I talked about risk factors, because the list, if you look at the list of risk factors, patients may actually have more than one risk factors that could actually be maybe not inciting the attack, but could make their symptoms worse. So for example, when we see patients with pancreatitis, we typically ask them with regard to exposure to, say, smoking. Until a few years ago, it used to be felt that smoking may not actually be important in causing pancreatitis or making pancreatitis worse. But we now know that smoking may be actually as bad or is even worse as compared to alcohol, as used to be considered before. Now, with regard to alcohol, often patients have questions with regard to, can I have a glass of wine here or there, or how much can I drink? Studies have shown that if somebody has had pancreatitis, their pancreas has become sensitive. And in that situation, exposure to alcohol can actually be problematic. Now, if somebody has, and not that I'm advocating this or that, but if somebody has a glass of wine or a little bit, once a year or something like that, that may not be completely bad, but just cutting down on consumption may not be the best idea, because that could still increase the risk. We discussed in the panel a little bit earlier about fat in the diet. One of the misconceptions that patients have is that you cannot have fat at all. Now, in specific situations, for example, Diana mentioned about hyperlipidemic pancreatitis. In that particular situation, you have to be very careful with regard to how much of fat you are taking or a composition of your diet. But if you take that specific situation out, I typically do not tell my patients with chronic pancreatitis to limit the fat completely. In fact, once you're taking creon, the function of the creon, or the way the creon works, is that it helps to digest food. So you need to have a certain amount of fat for your body to actually, you need a certain amount of fat for normal functioning of the body. So I tell patients to eat what a healthy, normal person would eat, and do not restrict the fat completely, even if they have insufficiency of the pancreas, but take pancreas enzymes along with that. Okay. So exercise, like common things that are good for all diseases, good exercise, paying attention to your diet and lifestyle, those are important.
And weight management
and
as
weight
well.
management.
So
correct.
let me just, we have 1 minute left, and I think this is a question Dr. Szigethy needs to answer. So you have about 1 minute. So we're spoiled in Pittsburgh. We have you for cognitive health needs. How do people who are not in this area find an expert if they want behavioral interventions like you described?
Well, I think one of the inadvertent positives that came out of our year of COVID is video and health technology sessions. So virtual sessions. And it looks like in most states, behavioral therapies are going to remain allowable by telemedicine and still billable. So I think that provides an opportunity. And all of those behavioral techniques that I talked about, I provided the entire year through my telemedicine clinic. I think the other good news is there is actually a field now of gastropsychology with specific therapists getting training in these brain gut techniques. It's a national organization. It is run out of the
We lost her. So unfortunately, her screen freeze, but I just wanted to thank your screen froze there at the end there. So, but I think this is really the time that we're supposed to end the discussion. But I want to thank everyone. Our speakers will try to answer any questions while they can. They've gotten to the majority of them, and we really appreciate everyone's attendance. We appreciate as a physician and healthcare provider, I appreciate the National Pancreas Foundation for supporting this webinar and allowing us to educate our patients. That's really why we're a healthcare provider. So thank you.
And thank you to our patients for participating in the session and sharing their experiences.
Thank you for both of our excellent speakers.
Thank you all for joining us, and we will follow up with you in an email after tonight's event. Thank you again.
Thank you all.